Today, we're going inside the operating room to break down a procedure so incredibly complex, it's basically one of the highest stakes balancing acts in all of medicine. We're going to explore the absolute limits of surgical skill. So let's scrub in and really get into the amazing challenge of the Whipple procedure.
You know, this is the big question for so many people who are facing really life-threatening conditions. When every other option is off the table, they put all their trust and really their lives into the hands of a surgeon for a procedure that is both their last hope and, let's be honest, an incredible risk.
So, here's how we're going to tackle this. First, we'll talk about why these huge operations are even necessary, and we'll use the spleen as our starting point. Then, we'll get to the main event, the Whipple. We're going to break it down into its two big phases, deconstruction and reconstruction. And then we'll look at the all-important human side of it all.
Okay, so to really get your head around a surgery as extreme as the Whipple, it helps to understand why surgeons would need to remove an organ in the first place. And the spleen? It's the perfect example. It's supposed to be our body's essential blood filter, but, well, sometimes the filter itself becomes the problem.
A perfect case is an inherited blood disorder like pyruvate kinase deficiency. Basically, a little genetic hiccup makes a person's red blood cells super fragile. So when they go through the spleen's filtration system, they just get shredded. The spleen is just doing its job, but the result is severe anemia. In situations like that, the only real fix is to take out the organ that's causing all the damage.
Cancers can also make the spleen a major issue. With lymphomas, for example, the spleen can get huge, causing a lot of pain or making blood cell counts drop to dangerous levels. That's a condition called hypersplenism, where the spleen basically goes into overdrive and destroys way too many blood cells. So taking it out, a splenectomy, becomes a key part of the treatment.
And it's a pretty similar story with some leukemias. When the disease is in its advanced stages, the spleen can get so packed with cancerous cells that removing it is actually the best shot at giving the patient some relief. So yeah, whether it's blood disorders or cancer, the reasons behind these massive surgeries are always incredibly serious.
And that brings us to our main focus today, one of the most demanding, most intricate operations ever designed. The technical name is pancreaticoduodenectomy, but everyone knows it as the Whipple procedure. This thing is on a whole other level of surgical complexity, so let's dive in.
Just look at this anatomical map. This is the surgical neighborhood for the Whipple, and it is some of the most complicated real estate in the entire human body. Everything is just jammed in there, the pancreas, stomach, liver, and this super dense web of blood vessels. See that portal vein? It carries all the nutrient-rich blood from your gut to your liver, and that's the superior mesenteric artery, a major highway for blood going to the intestines. One wrong move in here doesn't just cause a little bleeding, it can compromise the entire digestive system. It's incredibly high stakes.
So what exactly is a Whipple? Well, it's the surgical removal of not just one organ, but a whole collection of them. We're talking about the head of the pancreas, the first part of your small intestine, that's the duodenum, the gallbladder, and even part of the bile duct. All of it has to come out as one block.
To even make sense of an operation this big, surgeons break it down into 3 phases. First up is exploration, where they make absolutely sure the surgery is even possible to do. Second is the resection. That's the part where everything is meticulously taken out. And third is reconstruction, which is the mind-blowing process of putting the whole digestive system back together again.
Let's start with the deconstruction, the resection phase. Now, this isn't just about cutting things out. It's a systematic, incredibly careful dismantling of the patient's anatomy. The goal is to remove all the diseased tissue while saving every single critical structure that has to stay behind.
All right, so the resection usually kicks off with a cholecystectomy. That means the gallbladder is carefully dissected out and removed. Since it's attached to the liver and connected to the bile duct, which is also coming out, it just has to go. This is a pretty standard first step.
Next, the surgeon moves over to the stomach. They use a surgical stapler to divide the antrum, which is that lower part of the stomach. Doing this helps clear the way and gets the stomach ready for the reconstruction phase that's coming up later. Okay, this right here. This is the moment of truth. The surgeon has to so carefully divide the neck of the pancreas, separating the diseased head from the healthy body and tail. And this cut is made right in front of the portal vein, that blood vessel superhighway we talked about. The slightest nick here could cause catastrophic bleeding. There is literally zero room for error.
So, once the resection is done, the surgeon is left with the healthy part of the pancreas, the stomach, and the bile duct, but they're all disconnected from the intestine. What comes next is nothing short of biological engineering, building a brand new, functional digestive system for the patient.
And this is the result: a completely re-engineered system. A loop of the small intestine, called the jejunum, is brought up to act as the new hub. The surgeon then painstakingly reattaches the rest of the pancreas, the bile duct, and finally the stomach to this loop of intestine, creating a whole new pathway for food and digestive juices to flow. Now, the most critical connection of all is hooking the pancreas back up to the intestine. It's called the pancreatojejunostomy, and surgeons have a couple of ways to do this. On the left, you see an end-to-side technique where the pancreatic duct is sutured right to an opening in the intestine. On the right is an invagination technique where they actually kind of tuck the end of the pancreas into the intestine. The choice really depends on the surgeon's training and even the texture of the patient's pancreas.
The final big reconnection is the hepaticojejunostomy. This is where the common bile duct coming from the liver is carefully sewn to the intestine. This step is absolutely essential. It makes sure that bile, which you need to digest fats, can get from the liver into this newly rerouted digestive system.
I mean, the technical skill of the Whiple is it's breathtaking. But the surgery doesn't just happen in a vacuum. There's this massive human element, the preparation, the teamwork, and the patient's informed consent that is every bit as critical as any stitch the surgeon makes.
Before the patient even gets to the operating room, there is a mountain of prep work. It's this huge, coordinated effort, reviewing every single image and lab results, consulting with the ICU and anesthesia teams, getting IV fluids going, giving preventative medications, fixing any blood clotting problems. The checklist just goes on, and every single item is vital.
And then there's the consent. This quote is pulled right from a surgical text, and it outlines what has to be discussed. It really grounds us in what the patient is actually up against. The specific complications are terrifying: major bleeding, infection, and the dreaded pancreatic or biliary leak, which is when those digestive juices start leaking out from the new connections and just wreak havoc inside the body. This is the conversation that has to happen before a single incision is made.
And it leaves you with this final, really powerful thought. For a procedure this enormous, with risks this profound, maybe the true test of a surgeon's success isn't just about the perfect technical execution of the surgery. Maybe it all comes down to the deep trust that has to be built between a surgeon and a patient as they prepare together for the unthinkable.